We're going to just do we're going to talk about the normal anatomy. Normal lung anatomy, unfortunately, is a little complicated. There's obviously a whole bunch of stuff in the chest. Some of it is pretty straightforward to consider and think about. The shapes of the lungs, of the locus of the lungs are kind of weird, but their relationship to each other, the relationship to the front of the chest, the back of the chest, and the heart is important to understand, so we're going to take some time with that. The lining of the lung is important to understand how it's built, how it's made, and why pathologic entities occur and what they look like. So it's obviously very important to kind of understand what normal is and what normal looks like to really be able to appreciate and to recognize what abnormal is.
You should be coming on the other side. Messing up my video.
So, again, my particular search pattern in the chest, X-ray starts right in the middle. Okay, so I'm going to want to make sure that I understand what the airway looks like. The airway is usually identified as a column of lesser density that's superimposed on all the high-density bone and soft tissue structures in the superior median spine. But you can also usually see the left main stem bronchus and the right main stem bronchus. On the lateral view, you'll see the trachea just in front of a little bit in front of the spine. Okay. So the good landmarks on the lateral view are going to be, okay, the heart, which is in the anterior part of the chest, the spine, which is obviously posterior, and this general clear space between the sternum and the mediastinal structures. Kind of want to see that whenever you can. If there's a mass, if there's soft tissue density in there, that would definitely be a mass or something abnormal. If you take a little bit of a blow-up view of the large airways, you've got the trachea, and then you can kind of sort of see the right main stem bronchus. This thing here is called the carina. It's where the right and left main stem bronchi divide. You will often see a radiology report that describes something that has the word carina in it. It's probably not a word that many of you have ever heard before, but the carina really is the fork in the road, to paraphrase Yogi Berra. Okay, it's where the two major airways divide. And then the left main stem bronchus, you can usually see is a very subtle, low density, sitting up against the airway. Okay? You know these things don't really project very well. Again, we're starting in the middle, right? So we're going to talk about the heart and its anatomy a little later today. But I want to talk about these interfaces between the lung and the soft tissue, because just about at every level there's going to be an anatomic landmark that you can identify. Here's something that I think I'm going to hit on a little later, but I want to make very clear, very important. The only reason we see any on the chest X-ray is because of this density difference that you alluded to. The radio density difference. You can only see diaphragm line here because just above it is air. There's something of a different radiographic density. Just because this is all white, does that mean this is all one structure? Oh, heck no. There's bile ducts. There's all kinds of stuff. There's and all kinds of vessels. But you can't see them because they all have the same density. Here we've got different densities, different radiographic densities. And so we see the interface between the diaphragm and the lung. We see the interface between the right atrium and the lung. We see the interface between the left ventricle, which is here, and the lung. And so it goes. As you march up the left side, this is where the left main pulmonary artery is. There's a space between the aorta and the pulmonary artery called the aorticopulmonary window. There's the aortic arch, which is this knob, which is the aorta basically coming right at you, and then diving posteriorly and going down. Yes, sir? The diaphragm actually is a very thin muscular sheath. It actually you probably actually couldn't really see it if it just sat alone. But yes, it's mostly due to the soft tissue structures under it. But there is also a thin sheet of muscle there that's called the diaphragm. So we'll call this the diaphragm, for what we really mean is the interface between the abdominal cavity and the pendulum. Okay. Up here in the superior vena sinum, there are veins, the innominate vein, the right and left innominate vein. The superior vena cava is right here, and then the ascending aorta is coming out of the chest, going up this way, diving posteriorly where the knob is, the aortic arch, and then going down. And here you can see that there's a line called that is showing you the descending aorta, very posterior where the descending aorta sits up against the lung. Again, you can only see a line or an interface because there is a density difference. The good thing about the chest is that we've got all this aerated lung really acting as the other density so that we can see everything else that sits up against it. Okay, in the right lung, there are 3 lobes. It's very common for someone to look at a chest x-ray and go, well, I'd say, okay, I'm pointing to a lesion that is, say, here, okay? Where is that? Well, that's got to be in the right upper lobe. Well, that's often correct, but not always correct. Because you need to understand the way these lobes are situated in space. So the right upper lobe occupies the upper half of the right lung on a chest x-ray. Thank you very much. So the right upper lobe occupies the upper half of the right chest, and it also occupies both most of the anterior part of the upper chest and the posterior part of the upper chest. There's a second lobe in the right lung called the right middle lobe. Now this one is a little unique because notice how the right middle lobe goes all the way down to the nostril. Also notice how on the lateral view, the right middle lobe is very anterior. This is very important to understand because the right middle lobe shares the interface with the right side of the heart. So the right atrium, which is right here, sits right up against the right middle lobe. So if there is disease in the right middle lobe, we might expect that to affect the way we see the right heart border. And I'm going to show you that very important thing called the silhouette sign a little later. It will be in yellow text, and it's something that you're going to definitely want to be able to understand. So already you've just showed me the right upper lobe and the right middle lobe, and it looks like that's just about all the right lung. So what's left? But it's not all the right lung. In fact, the right lower lobe is bigger than both of them. Okay, occupies a lot of the right hemithorax. If I were to put a lesion right here and just showed you the frontal view and said, where is it? You might naively say, well, it's in the right upper lobe because it's in the upper half of the chest. And I would say, silly, I told you need 2 views. But if I told you that that thing was very posterior, okay, then you might say, well, there's probably, that could very well be in the right lower lobe. So don't jump to conclusions about where something is on one view. Make sure you get a second view. Okay? So 3 lobes on the right. Right upper, right middle, right lower. And we're going to show you in a little bit, those 3 lobes are divided around 2 fissures. Major fissure, minor fissure. I'll show you pictures of the anatomy of the chest. Something that you're going to use. It occupies the upper half of the chest. It also goes from anterior to posterior. If you go further posterior, the left upper lobe is higher and higher. Okay? In the left lung, there are only 2 lobes. Sorry. 2 lobes. Lingula, or anterior segment because it's sort of like with respect to the lingular segment of the might do something to the frontal border. That's how you would be able to tell that it was lastly, the left chest is the left lower lobe, which is also very large. Also goes very so a lesion sitting up here on the frontal view, you might just say it's in the left upper lobe. Collateral view, second view. There are two fissures in the right that divide the lobes. The fissures really are just invaginations of the lining of the lung. So picture the lung. And there's a lining of tissue. But where that tissue basically ducts back into the lung is where it divides the lobes. Okay? So on the right there are two fissures. There's a minor fissure, which divides the right upper from the right middle lobe, and it's pretty horizontal. And then there's a major fissure, which divides the right upper from the right lower lobe throughout its course and in its upper half, and from the minor and from the right middle lobe in its lower half. The major fissure is very long. The minor fissure is relatively short. So I know it's difficult to see in 3 dimensions. Here I've got, these are reconstructed CT scans, okay? This is the right lung. The patient's front is here. The patient's back is here. This is the right lung. This is the left lung. On this image, the patient's front is here, and the patient's back is here. Some of you in the front can probably see there's a thin white line. That's the major fissure on the right, dividing the right lower lobe from the right middle lobe here, and the right lower lobe from the right upper lobe here. This is the minor fissure, okay? And it divides the right middle lobe from the right upper. So 2 fissures on the right dividing 3 lobes, 1 fissure on the left dividing 2 lobes. This is the left major fissure. It's just 1 fissure, goes all the way down, divides the left lower from the left upper lobe. Any questions? Good.
Do you see the fissures on a normal chest X-ray?
Not usual. Okay. You can see them on CAT scan. You can see them on a chest X-ray if there's fluid in it. Sometimes if the fluid gets around the lining of the lung, it also then collects in the fissures. The right middle lobe is notorious for collecting fluid. It can look like a tumor, but it's really just fluid in the fissure. And there's several ways that we can tell that. But generally speaking, you will not see the fissures on the chest X-ray. You have to infer where they are, okay, based on. Sometimes what you'll see is if there's a lot of pneumonia in a lung. Let's say the left lower lobe has a big pneumonia. It might actually get swollen and push the fissure forward. So you might then be able to see where the fissure is. Okay, but in a normal chest X-ray with no pathology, we're not going to see it. A couple of other things we need to look at are the angles, the costophrenic angles. Costophrenic, rib diaphragm, costophrenic. So we want to see that angle where the ribs and the diaphragm look like they come together. Those are down here. Okay, we want to see them as sharp, very sharp areas. So on this one, it's a sharp angle. If there's fluid layering, a small amount of fluid layering in this pleural space, you're going to start to see that get blunted. When that becomes blunted or whitish, then there's something sitting in there. It's either going to be pneumonia in the lower lobe or fluid in the pleural space that blunts the costophrenic angles. So when you're looking at a chest X-ray, you're obviously looking at those midline structures. You're looking at all those borders to make sure that you can see them all well. You're looking at the costophrenic angles. Your eyes need to go to all of these spaces. Let's talk about the bony anatomy. Okay, I already told you that ribs are tricky. So we've got on a normal chest X-ray, we're going to see cervical, thoracic, and lumbar vertebrae. Mostly they're going to be thoracic, but you will see the lower cervical and the upper lumbar vertebrae. How many cervical vertebrae? And how many thoracic? And how many lumbar? And how many ribs? Most of the time. Okay. Sometimes there are almost always 12 ribs, but sometimes there are transitional lumbar vertebrae. Sometimes there are funky additional cervical vertebrae. But for all intents and purposes, you got all of that right. So the rib cage is made up of the ribs and the ribs which connect to the spine in the back and the sternum in the front. The sternum is notoriously difficult to see on the chest X-ray. There are dedicated sternal views, but those are those very shallow light views that have a specific technique to make the bone stand out. And we're penetrated to a chest X-ray. So the technologist knows how to do that. The sternum is a very weird looking bone and so difficult to follow. Then, of course, there are the things on the edge of the thumb, called clavicles on the edge, which is see the medial border of the scapula. You'll usually see the proximal humerus on either side. Spine. It's not very easy to count thoracic vertebral bodies or thoracic segments on the chest X-ray. It's sometimes on the lateral, you can see where the rib comes off. And here you can never be sure which one is 12. Sometimes you can see which one is 12. I wouldn't worry too much about counting vertebral bodies on a chest X-ray. Ribs, though, is something that you can see one, and you can start with 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Posterior rib, 11 and 12 usually get lost in the sauce. Okay, but you can usually see one, and if you can see one, you can count. Yes.
Can you trace one
So this is the transverse process of T1. This is the top of the first rib. It goes like this. It's going to go like this. I'm sorry you don't have the slides in front of you. But that would be 1. So the one immediately below it's going to be 2, and it comes out here like this. And then 3 comes out here like this. Okay. It's usually easiest to start with. You can almost never see the anterior ribs reliably. So it's usually best to start with the posterior ribs. And if you can get to 1, if you can see 1, then you can usually infer where the rest are.
We'll look more clearly in this one than the anterior ribs.
These are posterior ribs. These are all posterior ribs. You almost never see the anterior ribs because the anterior ribs quit. So I'll just take this one for a second. This one goes out like this. This one goes like this. This one over there. And it's all cartilage. It's an anterior rib. If it's directed this way, it's an anterior rib. If it's directed this way, it's a posterior rib. This one. Time you look at the shape of it.
So is the 10th rib resting almost directly on the diaphragm?
I beg your pardon, sir?
Is the 10th rib almost resting directly on the diaphragm?
This is the posterior 10th rib.
Okay.
It's all the way back here. But you say it's resting on the diaphragm.
I don't know if it was.
On the image, it looks like it's resting on the diaphragm. In real life, it's not really near the diaphragm. Are we good?
Yep.
On the lateral view, you will see these usually almost square-shaped vertebral bodies. You want them to be of about the same height in the normal.
You are being watched.
Just making sure I'm doing it. So you want to make sure that the vertebral bodies are about the same height. In older folks, especially in older women who have compression fractures, one vertebral body will be like flat like a pancake. The next one will be relatively long. Okay, so here's the ribs. Okay, thought I had this slide. Okay, so here's the first rib. This is the outline of the left first rib. Here's the outline of the sixth rib. Okay, notice how it goes down and then it starts turning and it comes this way. So the anterior sixth rib could be all the way down here. The anterior, luckily, as the ribs get lower and lower, they get shorter and shorter. There really is no anterior 12th rib. And in some people, the 12th rib may be that long, and it may be that long, it may be that long. But it's never going all the way around and coming. The 12th rib is very short. 11 is a little longer, 10 is a little longer than that. Let's not forget the clavicle. So there's the medial end of the clavicle, which has a joint with the sternum, the sternoclavicular joint. Then there's the clavicle. Then there's the acromioclavicular joint, where the acromion of the scapula and the distal clavicle have a joint. And then you may or may not see the scapula. There's the scapula right here. You can see the edge of the scapula. And you can sometimes see it on the lateral view. All right. Let's talk about the anatomy of the circulatory system. Okay, we may do a little more of this in this last hour of the lecture. But let's talk about the heart. The heart is, unfortunately, not like the heart on your Valentine's card. The heart is a tremendously complex structure. I'm going to tell you that it probably took me 6 months of solidly thinking about the way the heart sits in the chest. It wasn't until I was in my internship and I was doing my transitional internship when I was in cardiothoracic surgery, and I could actually see the heart beating in the chest to understand the way the heart sits in the chest. So you're not going to get it just by me telling you about it today, although I'll do my best. The things that I want you to understand about the heart is that we know there are four chambers, okay? 2 atria above, 2 ventricles below. What I want you to understand is what's anterior in the heart and what's posterior in the heart, and what are the surfaces of the heart that above the wall, because that's the way you're going to be able to tell which cardiac chambers might be enlarged, which pulmonary structures might be abnormal. Okay? In this cartoon, the anterior structures are in blue. Okay? The right ventricle and the right atrium make up the anterior structures of the heart for the most part. When you look at a picture of a heart in a chest, this is the heart. You're essentially looking at the right ventricle. The left ventricle is the pumping chamber, right? But that's a posterior ventricle, and so is the left atrium. So the left atrium sits on top of the left ventricle, but the left ventricle makes up the posterior border of the heart. The right atrium makes up the right border of the heart. All the way out on the left ventricle makes up the left border of the heart. Okay? So on the lateral view, the anterior border of the heart is the right ventricle, and above is the right atrium. So on the lateral view, right ventricle, left ventricle. On a frontal view, right atrium, left ventricle. You don't see the left atrium on the frontal view. You will see the left atrium when it gets really big on the lateral. It'll get way big. So let's not worry too much about how the heart sits, and it doesn't really look like a heart, it's all that kind of stuff. Let's just remember which are the anterior borders, which are the posterior borders, which are the left borders, and which are the right borders. Any questions about that? Good. So out of that posterior left ventricle, comes the aorta. So it's coming from posterior along the right side. The ascending aorta goes up, and then it basically goes straight back. And we call that the aortic arch. What we're really doing is looking right down the bore of the tube. Okay, so the aorta comes up, and we're seeing it when we say that it's a French term, en face. So you're looking at it like in front. It's coming out, and then it's turning, and it's going back. And then you're looking at like right down the bore of the tube. That's the aortic arch. That's that knob, the aortic knob, or the aortic arch. And then posteriorly, right along the spine, the aorta descends into the abdomen. That's the descending thoracic aorta. So the arch comes up and makes a little bump here in the mediastinum, Then you get the arch on the left, which is usually on the left, because the arch goes up and then crosses the midline, goes back and then goes down. And that's where we see the left side of the aortic arch. And then the aorta descends on the left side. Now on the lateral view, you can see how the left ventricle would be pumping its blood this way. Here's the arch. It's this thing right here that is the arch. Okay? Because you're looking right down the bore of the tube and then the descending aorta. There's my thing. The veins you generally will not see. The superior vena cava will make a subtle border along the medial side of the right upper chest, and the inferior vena cava you almost never will see it. You obviously know it's there, but there's only a very short segment of the inferior vena cava that has lungs stuck up against it, because the inferior vena cava basically comes out of the liver and then essentially immediately dumps into the right atrium. So there's very little place for the IVC to be sitting up against the lung. So that's why you don't see it. Superior vena cava might sit up against the lung a little longer. On the lateral view, this is where the IVC would be. This is where the SVC would be. Now the pulmonary vessels are those vessels that are taking blood away from the heart into the lungs, or taking blood back from the lungs into the heart. You basically want to see these vessels kind of out to about halfway. They're going to be kind of wispy. They're going to be kind of tubular in shape. They're going to be a little, obviously they're going to be brighter, whiter than the surrounding lung. The only reason you can see them is because they're surrounded by the lung. But you don't want them to be too fat. You don't too large. And what's too large? Well, you got to look at thousands of chest X-rays to kind of know what too large is. But out of proportion, they're not going to be out of proportion, and you're going to see them here. The pulmonary arteries and pulmonary veins converge into the thing called the hilum. There's the right hilum. You'll see the radiologist talk about a right hilum and the left hilum. So the hilum is where, and this is not just true for the chest, it's true for every organ that gets a blood supply. Almost every organ has a hilum. Each lung has a hilum. Blood vessels connected. We're going to talk about this in a little bit. I want you to start thinking about the anatomy of the lung itself. So, discuss the gross anatomy, the lobes, the fissures, the airways. How does the lung actually work? How does it actually, what does it do? It exchanges gas, right? It exchanges oxygen, carbon dioxide, and the air spaces. So the microanatomy of the lung is something that you would say, well, why do I really care about the microanatomy of the lung? I can't really see that on the chest X-rays, so it's really small. Yeah, but what the microanatomy is telling you is it will tell you that the pathophysiology. So the airway, the terminal airway of the lung, basically starts popping off these little alveoli. This is where the actual gas exchange happens. This is where the venous blood, where the venous blood gets oxygenated and then comes back into the heart. So it's funky really because the pulmonary arteries, we think of arteries as the vessels that carry oxygenated blood, but the lung is different. In the lung, the pulmonary arteries carry deoxygenated blood away from the heart into the gas exchange mechanism of the lung, where they become oxygenated, and then the pulmonary veins bring the oxygenated blood back to the left side of the heart to get pumped around. Right? We'll go through this again just as a review. I know you guys probably won't do this, but there are two sets of tissues in the microanatomy of the lung that we need to be aware of. There's the air spaces where the gas exchange actually happens, the alveoli, and then there's the interstitium of the lung where there's no gas exchange that's happening there, but the interstitium is actually holding the lung together. Okay, so it's what holds all the alveoli together. It holds the airways in place. There's lymphatics in there. There's blood vessels that feed the interstitium. But for our purposes, for the chest X-ray, let's think about the air spaces and the interstitium. Their appearance when there's pathology is going to be different. and it's going to be able to help you understand where in the lung the abnormality is. Is it an airspace disease, or is it an interstitial disease? So, let's start talking about the pulmonary abnormalities. There's the alveolar abnormalities, the airspace abnormalities. These tend to be fluffy, rounded opacities or densities that you can sometimes draw your finger around, but usually aren't clearly demonstrable. You can't really sometimes, most of the time, you can't take a pencil and draw the abnormality around these airspace abnormalities. Now, tumors of the lung, a mass, lung cancer, usually you can pretty much draw a line around it on a chest X-ray. So this is a definitive mass in the lung. These airspace abnormalities, because there are so many millions and millions of alveoli in the lung, some of them may be diseased, some of them may be not. When I say disease, what do I mean? Well, what's in the air spaces in a normal lung? What's in the air space? Air, right? So something has to fill that space when it becomes disease. Could be pus, pneumonia, okay? Could be blood, alveolar hemorrhage, right? Could be salt water, fresh water, drowning, okay? These are all airspace diseases that are going to manifest on chest X-ray, okay? Now, tumors of the lung are actually, they're usually in the airspace and in the bronchi. So, a bit of a caveat, but let's just consider ourselves right now talking about airspace diseases from pus, pneumonia, blood, or protein or cells or tumor. And then there are the diseases that involve the interstitium. They tend to be linear or nodular. They're not in the air spaces, and so they don't tend to coalesce. Airspace disease tends to coalesce, so that there's this big blob of abnormality. Interstitial diseases tend to be more wispy, and they tend to be a little more micronodular. And then there's the third category of disease of the lung, which is what happens when the lung collapses. Okay? And there's this word, there's this beautiful Greek word called atelectasis. Another word you've probably never heard until today. But atelectasis means an absence of air, or an absence of expansion. So atelectasis really means the lung has collapsed, or a portion of the lung, and just a part of the lung has collapsed. And that collapse is very important, and we'll be able to tell the difference by the time we get done here. Between atelectasis and airspace. One of those things that would be very important. Now we're going to talk about this. Now we've talked about the anatomy of
Isn't Alex, a lot of times positional can be resolved with moving or a deep breath. It's not fixed with that anymore.
right. It's not analogous. You are right that when you have any major surgery or see anyone with major surgery, is they do this thing. They breathe out, breathe in, do this thing as much as you can. And atelectasis can be when patients recover. So once it's there, you definitely want to follow. You want to make sure it gets better. Presumably for like the post-op stage, you've got to do the incentive spirometry. So that incentive spirometer in front of that patient is really preventing him from getting atelectasis. Well, how bad a deal is atelectasis? Well, you decrease your gas exchange when the lung doesn't work, when it's all collapsed. And atelectasis does get infected and turn into pneumonia. So you definitely want to get that lung re-expanded as soon as you can. So, I've already hit on this a little bit, but I want to come back to it again because the silhouette sign is really crucial. We talked about the 5 densities. And we talked about the only reason why you can see anything is because there's got to be 2 different densities in abutment with each other. So the density of the lung, the air density of the lung, the soft tissue density of the heart is the only reason why you see that margin of the lung and heart. So what happens when you have disease in the lung that is abutting a soft tissue structure, a essentially turned the air-filled lung into a pus-filled lung, what happens to that interface between the heart and the lung? Well, it goes away. And that's called a silhouette sign. So that's how you know that there's disease in the lung, but that's also how you know where in the lung the disease is. So, okay. You're so far left there, so I don't see that. Never mind. Very cool. All right. Watch the silhouette sign. Okay. So then you know it's really. So we've been through these margins, right? The right upper lobe sits up against the aortic arch. The right middle lobe sits up against the right atrium. The right lower lobe sits up against the diaphragm. The lingular segment of the left upper lobe sits up against the left ventricle. The left lower lobe sits up against the left diaphragm. And the left upper lobe sits back here up against the aortic arch. So if I have disease, say, in the lingula, am I going to see this interface? I'm going to lose it. I'm not going to be able to see the left border of the heart. If I have disease in the right middle lobe, I'm not going to be able to see the right heart border. It tells me pretty much definitively that the disease has to be there. Well, what happens if the disease is in the right lower lobe, right? Let's say it's not even up against the diaphragm, but you already told us the right lower lobe is really big. So what if it's in a portion of the right lower lobe? Well, I'm going to tell you, if I can see the right middle lobe, if I can see the right heart border, I know it's not in the right middle lobe. It has to be in the right lobe. And so there's this active way of telling where something is, and then there's a passive way of excluding where it isn't to be able to tell where it is. So here's the silhouette sign. There is an infiltrate in the lingular segment of the left upper lobe. How do I know that it's in the lingular segment?
You don't see the left heart.
You don't see the left heart border. I can follow this border right here. There's aerated lung here up against the aortic arch. There's aerated lung against the hilum and pulmonary artery, and then it's done. Now all I get is this big white mass. That has to be, but you would say, I don't really see the diaphragm there either. Is it possible that he has disease in two lobes? Sure, it is. But I definitely know he has disease in the lingular segment of the left upper lobe because I don't see the left heart border. I wouldn't be so tricky as to show you this. I wouldn't expect you to. If I showed you something like this, that's going to be lingular. Okay. So the silhouette sign on the left cardiac margin becomes invisible if there's an adjacent lingular consolidation. The left aortic arch becomes invisible if there's a left upper lobe consolidation or mass in the left upper lobe that's abutting the aorta. And the left descending thoracic aorta margin would become invisible if there's a left lower lobe consolidation, and also the left diaphragm. Okay. On the right side, the right cardiac margin becomes invisible if there's something in the right middle lobe. The right paratracheal and superior vena cava margin becomes invisible if there's a right upper lobe consolidation. And in the right lower lobe, if there's disease there, the cardiac margin should not be invisible, but the diaphragm may become invisible. So think about this a little bit, and when you're looking at the books and looking at the pictures, try to get that, those spatial relationships in your mind. So, here's an image. Anyone care to opine on this one? What are you seeing? How would you describe this? There's an opacity, okay, in the lower half of the right hemithorax that obscures the right heart margin. Does it obscure the right margin of the heart? If this is the heart here, what you would expect the margin to be about here. Okay, it's gone. This density goes all the way out to here. That's not all heart, is it?
Hope not.
So there's an opacity in the lower half of the right hemithorax obscuring the right heart border. The conclusion is right in the middle of airspace opacity. Okay. I can't tell you for sure that's pneumonia. I can tell you that there's something in the air spaces of the right middle lobe that is causing the density of the heart and the density of the right middle lobe to be the same. And so that could be pus, could be pneumonia, could be blood, could be tumor. For the moment, we'll ignore that stuff out there, which is probably also an infiltrated lateral in the right upper lobe. But notice how you just don't see that right heart word. Sometimes it's harder to recognize what you don't see than what you do see. And that's the beauty of radiology. So there's the silhouette sign, and then its friend is the air bronchogram sign. These lung segments and lobes that get diseased, these airspace diseases, where the airspaces get filled up with something, pus, blood, whatever. Remember that there are tubes of air that are supposed to be bringing air into that lung. Those tubes are not necessarily all microscopic. As you get closer to the hilum, the tubes get bigger and bigger, right? So what happens if you've got a segment of lung that's full of pneumonia, but the tubes still have air? And the tubes are big enough that you could actually resolve them on an X-ray. You might actually see those tubes inside the lung that is diseased, okay? So the tubes still have air in them, but the air spaces have pus, okay? This is what's called the air bronchogram sign, and it's commonly seen with airspace consolidation. When I say airspace consolidation, I'm talking about anything that's in that airspace. Most commonly, it's pneumonia, but it could be blood. It could be edema. It could be that the heart isn't working well, and we'll talk about this a little later this afternoon. If the heart isn't working well enough, and that the serous fluid is backing up in the lungs and filling up the air spaces, because the heart can't pump. It can't pump strong enough to keep the balance of blood going out of the heart and blood coming into the heart. It can't keep that balance. When that balance gets screwed up, then generally speaking, water backs up in the lungs, and it's called pulmonary edema or congestive heart failure. You've probably heard those terms. So those air spaces fill up with water. But if the tubes of air still have air in them, you're going to see that those air-filled bronchi standing out against the background of fluid-filled alveoli. Now, if the fluid gets up into the airway itself, now the airway has fluid in it, the air spaces have fluid in it, you're not going to see the airway as a thin, lucent line inside of the abnormal lung. So there was that thing. And now, I want you to hallucinate with me for a moment. Okay? Here's the big consolidation. Where would you think that would be? Just not a frontal view of the chest. Right upper lobe. That is in the right upper lobe. This is actually that minor fissure. The whole right upper lobe here is filled with consolidated. It's filled with something, pus, blood, edema, something. But see if you can make out these little tubes of lucency. Kind of here, kind of here, kind of here, here. That's the air bronchogram sign. Okay? That pretty much tells you that this is an airspace disease, and if you told me that patient had a white count of 20,000 and had a fever, and I looked at that chest X-ray, I'd say that patient has a bacterial pneumonia. Okay, that's bronchopneumonia.
If that was filled with fluid, wouldn't the fluid be drawn to the bottom of the lung because of gravity?
It would be if the lung were in hollow space, but the lung tissue is not hollow. The fluid is not in a hole. The fluid is in those tiny micro alveoli, okay? And there's millions of them. In that segment of lung alone, there are hundreds of thousands of alveoli, right? The fluid is only in each one of those little alveoli, but they're within the structure of the lung itself. Now, if that fluid were in the pleural space, which is continuous all the way around the lung, and you stood the patient up, dead, it would layer down here. It would be down here. There's a meniscus sign, I'll show you that later. Yes?
Is the fluid generally coming from, like, the blood plasma?
It would be, yes, in the case of congestive heart failure where the heart can't keep up with the pumping, right? Where the blood coming into the heart and the blood going out of the heart get out of balance because the heart can't pump fast enough or hard enough. then what you get is serous fluid, edema, backing up into the lung. Now that's not generally what this looks like. It doesn't look like this. But the fluid I'm talking about here really is pus. It's neutrophils and pneumonia. It's an infectious process of the lung that's filling up those alveoli.
So in this case, if you were to do a lateral defibrillator, that fluid would not move.
That would move. That would stay exactly where it is because it's not like I said, it's not fluid like in a balloon. That would slosh around. Right. It's fluid in all those tiny little alveoli that if you turn the lung, it's still going to stay exactly where it is. If it were in the total space around the lung, you would expect it to destroy. So that's the air bronchogram sign. Let's see, I may have another one. Okay. Here the entire, this is actually an interesting thing. We obviously know the problem is on the left, the patient side, right? But tell me where it is. You can actually tell what lobe that is in by looking at that image. What do you, first of all, can you see the diaphragm?
Yep.
Yes. So probably not in the lower lobe,
Mhm.
at least not all of it in the lower lobe. Can you see the left heart border?
Yes.
Yeah. Although it's kind of wispy here. This is most of the left upper lobe is involved with this, okay? But notice how the left upper lobe comes all the way down. I mean, it comes all the way down to here. So don't allow yourself to be fooled by, just because it's upper or lower, means it's the upper lobe or the lower lobe. I mean, if that disease were just confined here, it could still be in the upper lobe, but it's in the lower half of the chest. But look again for these wispy lines of low density, this kind of darkish lines here, darkish lines. That's the air bronchogram sign. Okay? So air bronchogram sign, alveolar airspace consolidation.
It's just a little funny because on a healthy lung, those sides are wider. I guess, like a healthy lung tissue, like the lung is clear, and then you can see the same. I guess venous artery size.
I'm not sure. So here's a healthy lung.
Yeah. So the white markings.
The white markings.
Wouldn't that be the same structure on the other side?
No, sir.
No.
The white markings are vessels. They've got blood in them.
Oh, okay.
These got these, and so these are normal, and it's got blood in them. The dark markings here are airways.
Okay.
They have air in them. Okay, so not the same structure. You can't see the blood vessels that are in this lung here because their density is the same as the disease process in the lung, right? Okay, so we're going to come back to this slide again because it reinforces that whole idea of, I'm sorry.
So in both of the pictures that you just showed, that one and the one before, the disease is in the actual lung, not in like the bronchial tube.
Exactly right.
Okay.
The disease is in the lung. The only reason you see the bronchial tubes is because they have air in them. The lung has fluid or pus or blood or whatever else, whatever the disease process is. Now, ultimately, those airways will get filled up with crap, okay, and then you will see them all. But these are, I love seeing cases like this because it's bronchopneumonia next case. I mean, you see that air bronchogram sign? It's almost always that's what it is. If there is a differential diagnosis, weird tumors of the bronchial cell, bronchoalveolar cell carcinoma, things like that, but generally, gastric airways. So here's that picture again that I want you to kind of burn into your mind about these tiny little alveoli. What you're not seeing really here is the interstitium, is the support structure, everything that's holding those alveoli together. So all of the lymphatics and all of the other blood vessels that are sitting around here that make up the interstitial tissues of the lung. When disease does involve those tissues, there can be enlargement of the lymphatics. There can be sarcoidosis, which is an interstitial lung disease. It doesn't involve the airway so much, but it causes the small lymph nodes in the lungs to get big and all the lymphatics to get big. Okay, so it's that supporting tissue that tends to have a linear or nodular appearance to it. Okay. I'm consciously downplaying interstitial lung disease here. because there are textbooks written about interstitial lung disease. The thing that I want you guys to be able to tell the difference is what's airspace, what's interstitial, and because airspace disease is so much more prevalent, and for the things that you're going to be taking care of, especially early on in your careers, your ICU patients, your patients seen in the clinic with pneumonia, et cetera. I want you to really be able to identify airspace disease. So interstitial lung disease, and I'm going to show you a couple of pictures of it here. I mean, you would say, well, wow, that doesn't really look abnormal at all. But there's, it doesn't be very well here. But there's small nodular densities, and there are wispy densities here. That would be nodular stuff here. That would be, starting to talk about these are interstitial processes. Like I said, I'm willfully taking very little time to talk about interstitial lung disease, but I don't want you to get too bogged down.
Less dense with area in the diaphragm?
No, wait a second. It's air in the stomach. It's surrounded by soft tissue. So here's a nodular interstitial lung disease. Now, notice how all these tiny little nodules, some are larger than others, they don't really coalesce into one lobe, right? They're scattered bilaterally all over the place. This would be a patient who has sarcoidosis, which is a fairly common disease. Now let's talk about this thing called atelectasis. And before we start talking about it, I want to think about the commonly word that not only is useful in the lung, but it's useful in the brain. It's useful in a lot of places. And the phrase is that nature abhors the vacuum. Okay? If you take air away from something, and something else is sitting next to it, that something is going to move to fill the space. Okay? If you take air out of a lobe of the lung, then in a closed space in the chest, some structures are going to move to fill the space because it's not just going to sit there with the vacuum. Okay? Something is going to fill the space. Now, when we're talking about airless lung or atelectasis, things are going to shift depending on how much lung actually becomes airless. So, when only a little bit of the lung segment becomes airless, let's say you've got a whole right to lower lobe of the lung, but only a small segment of it becomes airless. Not a lot of stuff is going to do it, and you're not going to notice it. But what you'll see is these little plate-like areas of linear density. Okay? So that little bit of the lung has not expanded for some reason, or became collapsed and didn't re-expand. Patient went to the OR, was under anesthesia for 4 hours, came back, was on a ventilator for 2 hours, got extubated, is breathing on their own, but all that spongy lung that kind of got collapsed during the surgery because it wasn't being super well ventilated, didn't start to pop back open. So now you've got these areas of atelectasis or airless lung, kind of linear areas out here, a linear area over here, over here. So that could happen, and that's why we give the incentive spirometry. You give someone incentive spirometry with this amount of atelectasis and they're healthy, otherwise they're going to pop that back open, it's going to go away.
The right film looks underexposed?
It probably is. It probably is, and it might be just this light through here. So it's a good observation, but I wouldn't worry too much about it. Let's just say that it's in the spectrum of acceptance. Okay? And in medicine, like in life, you just got to sometimes take what's acceptable. That's all you get. But if larger segments of the lung begin to collapse, then things are going to move, or things are going to start to look different. This is a representative slide of right middle lobe atelectasis. Okay? On the frontal view, Would you agree with me if I said, I see the left heart border real good, I see that real good, I see that real good, I see that good. Then I get to the right heart border down here and I'm not seeing it so good. Would you agree with me? So if I were just to look at that film, not knowing anything, I would say there's a strong likelihood this patient has a pneumonia in the right middle lobe. Right? That would be right middle lobe, right? But then if you showed me the lateral, I would be seeing this wedge-shaped density, just like this. And I would say to myself, the right middle lobe should be much bigger than that. It should be really much bigger than that. But now something is collapsed. The right middle lobe has collapsed. And actually, the right major fissure is being pulled up. And if I look at this, and I look at this, I go, okay, the reason why I don't see the right heart border well here is because the right middle lobe is collapsed. And it's now, instead of being air density, it's soft tissue density. And so I'm really helped by the lateral lines. I know it's the right middle lobe. Why? Why do I know it's the right middle lobe on the lateral? Because it's very anterior. Okay? It's that really anterior lobe that I showed you earlier. So between these two things, I can infer that the right middle lobe is collapsed. Now, we've gone from little plate-like areas of collapse to the lobe that's collapsed. What if the whole lung is collapsed? Now what happens? So here is what we call the opacified hemithorax. The opacified hemithorax can be caused by a number of things. We also will say that this is a white act of the lung. Okay? You'll hear that term. But just because the hemithorax is opacified, that the lung is whited out, doesn't tell you anything about why. There are several reasons why that could be. That patient could have just come out of the OR and had that lung removed. That hemithorax is going to be full of fluid. It's opacified. Doesn't have a lung. The patient could have a pneumonia involving the entire lung. It would be opacified. Or the patient could have the collapse of the entire lung, and it's opacified. So how do I tell the difference? Assuming that I know the patient didn't just come out of the OR. How do I tell the difference between the opacified lung because of collapse and the opacified lung because of pneumonia or tumor or whatever? Sorry? The lateral view will probably not help you. What will help you here is nature abhors a vacuum. Okay? In the collapsed lung, you've got this gorgeous lung full of air, right? And for whatever reason, it becomes collapsed. The airway becomes obstructed, which is often what happens. Or the patient gets intubated, and they're very aggressive with the tube, and they put the ET tube in. Has anyone ever seen an ET tube placed? ET tube goes in, and it keeps going, and it goes into the left mainstem bronchus. So the ventilator is just pumping air into the left lung, and the right lung ain't getting in. And before you know it, over time, the right lung will just collapse. And you'll get this. So how will I know that this is collapse and not pneumonia? Because nature abhors a vacuum. And if this lung collapses, something has to be filled. The left lung is going to push over. The mediastinal structures are going to get pushed to the same side as the abnormality, the ipsilateral side. These are two words you probably want to become familiar with. Ipsilateral and contralateral. Ipsilateral means that the process is happening on the same side. Contralateral means the process is happening on the opposite side. Okay? So here here's the aortic arch. Where the heart border is over here, the spine is like almost right there. You can't see the right heart. It's all over here. The mediastinal structures are being pushed from left to right by the full aerated left lung. So the left lung is normal. It's got a bunch of air in it. In fact, it's got more air in it than it usually does because there's no air in the right lung. And it's pushing all that stuff from left to right because nature abhors a vacuum. That's how I know the right lung is collapsed. So the differences between pneumonia and atelectasis is there's volume loss in atelectasis. In pneumonia, the lung is either of normal volume or actually maybe swollen and big. Yes, sir.
Is that hyperinflation of the other lung a function of the body trying to compensate, or is that
Yes.
a mechanical process of the vacuum?
It could, well, no, it's usually the body is doing everything it can to get air into that lung and expand every spare alveolus, right? Sometimes you can get a ball valve mechanism that would pathologically expand the lung. You get that sometimes with kids. What they'll do is they'll get a peanut or something stuck in the bronchus, but it won't really occlude the bronchus. What happens is the kid can breathe in and get air into the lung, but when he breathes out and he increases intrathoracic pressure, it closes down and the air can't get out. So you get this ball valve mechanism, so you'll have one lung which is really, really, really overinflated, and the other lung which is normal. That's not what's going on here. Okay, here this is a physiologic overexpansion because the lung is filling the vacuum that's caused by the right lung being collapsed, and just like every spare alveolus is being filled. So also in atelectasis, you're going to get a shift to the same side of the abnormality. And in pneumonia, you won't get a shift necessarily, but if the lung is really, really swollen, you might actually get a shift away from the abnormal side. Okay? These atelectatic segments tend to be linear or wedge-shaped when they're not completely, when the whole lung isn't involved. Right? This is a wedge-shaped appearance. The one I showed you here, these are kind of linear wedge-shaped. But airspace consolidation in pneumonia tends to be rounded, fluffy, larger. The apex of these wedges are at the hilum. So notice how this wedge goes all the way back to the hilum of the lung. There is no really hyalocentric process going on here. But air bronchograms can occur in that. It's actually somewhat less frequent, but that air bronchogram almost always means pneumonia or airspace consolidation, but you can see it in atelectasis. So let's talk a little bit about, let's talk a little bit about emphysema and overinflation of the lung, pathologic overinflation of the lung. I think we will get a very good for this. So we looked at all those tiny little alveoli sitting nicely on the end of their airways, and that's normal. But there are many disease processes, including emphysema, often caused by smoking or other inhalational lung diseases, that cause those alveoli to break down, to coalesce, to get bigger and bigger and bigger. And so you get larger air spaces in the lungs, and then to add insult to injury, when the air spaces get too big, all the muscular coverings of the airways, every time you exhale, you not only use your chest muscles to exhale, which increases thoracic pressure, which pushes the air out of your lungs, but these smooth muscles around your airways also constrict to push the air out. That smooth muscle on the airways all gets shot. So all this air now is sitting in these big balloons in your chest, and you can't go anywhere, you can't get out. And so you get these overinflation, this chronic pulmonary overinflation, so that these airways, so that the lung becomes super overexpanded. The diaphragms get very flat, okay? The space behind the sternum, which you would see on a lateral view, gets accentuated, and because all that air is now sitting between the heart and the sternum in the lung, and the heart shadow becomes very narrow. So this is what COPD or emphysema might look like. So what about tumor? What about lung tumor or nodules in the lung? Always remember that tumor does not mean cancer. Tumor means growth. Okay? There are benign growths and there are malignant growths. A pulmonary nodule may be a lung cancer, but it may also be a granuloma, a benign granuloma, maybe one of many, many, many things. But generally speaking, if I describe something as a pulmonary nodule, it's generally, less than 3 centimeters in size. A mass I would refer to as greater than 3 centimeters in size. If it's calcified, if you can see that calcium density on a chest X-ray in a nodule, pardon me, it is almost always benign. We all, depending on what part of the country you come from, you will have been exposed to histoplasmosis as a child. Histoplasmosis in the lung gets a calcified nodule around it, and it just becomes a benign thing, not to be confused with a lung cancer. Some lung cancers can calcify, but very uncommon. So if you see a solitary pulmonary nodule on a chest X-ray, you can't be very specific about what it is. All I will say is there is a solitary pulmonary nodule. I'll wish that I had a prior, because if it was there 5 years ago and it's not changed, it's benign. Okay? This is why I will beg for priors. And if I don't have a prior, I'll say you need to follow it with another chest X-ray in 6 months. Or if you're suspicious that the patient may have a malignancy, you might need to do another test like a CAT scan or a PET scan. Okay, which would be very, very good for these solitary pulmonary nodules to tell you if they are malignant or not. And then, of course, you can always stick a needle, which we do under CT guidance. It's kind of like a game of darts. You find the lesion, you mark it out on the chest, and on the chest, take a dart, and take a needle, and it's so much fun. So here's a bigger nodule in the right chest. Here's a chest CT. There are some indications here that this is actually a tumor because it's irregular. It's got this kind of wispiness to it. So here's just an example of a pulmonary nodule, and the CT evidence. You realize on CT that the CT scan is like your body is a bologna, and the CT scanner is the slicer, and they're just making slice after slice after slice, and they're building up a whole set of images of slices. And so when we read CT scans, and we'll go over this again probably when we look at some brain stuff, and then next year we'll talk more about it. But it's really just looking at one slice after another, almost in a video. When you're looking at it, you're building all those 3D images in your mind. Yes, sir.
So about the CT, just looking at the left image,
Yep.
what are those like lumps towards the mediastinum and
Here.
then like the opacity towards the bottom? Like,
Okay, we're referring to this kind of stuff here?
yeah.
Okay, these are going to probably be normal pulmonary vessels. Okay,
Okay.
Remember, where all the blood vessels come together, this is where it gets most dense. And so this is where you're going to see more of the whiter stuff. It's certainly possible that there are enlarged lymph nodes in here, but chest X-ray isn't the way to tell that.
You don't usually see it that opaque, do you?
Yeah, you usually do. Actually.
Okay.
Yeah, I mean that actually would be within the spectrum of normal. Okay.
And then the opacity down towards the
Down
diaphragm
here?
on the left, on the lateral part.
Out here?
Yeah. And
Oh, out here.
Yeah, that area. Oh.
Female patient breast. Okay. This is the normal breast.
I meant inside the lung area.
Here.
No, left. Right there. That is stuff.
Whew, dude. That was normal.
Okay.
Let's talk about the pleural space. I indicated to you that the lung has a lining. The lining of the lung is actually 2 layers thick, separated by a potential space. So in that potential space, normally lives a very small amount of fluid, really just enough so that it acts almost like to keep the friction low between the lining of the lung, between the 2 layers of the lining of the lung. The 2 layers of pleura are called the parietal pleura and the visceral pleura. The visceral pleura sits up against the lung parenchyma itself. The parietal pleura sits up against the chest wall. And in life, and normally, as I said, there's just a small amount of fluid in that space, and it's a potential space. We never see it, and we never really would think about it unless something gets in there. And what can get in there is fluid, infection, tumor, for the most part, and blood. Okay? Someone's in an MVA, and they come in to the ER, and a chest X-ray is taken, and they've got a whiteout of the chest, good chance they've got acute hemorrhage into that pleural space, okay? And their lung is actually going to be secondarily collapsed by the congestion of blood in that space. Remember, nature reports vacuum. If you start putting fluid into the pleural space, then the lung is going to become collapsed as that fluid gets more and more volume, right? We talk about, in the pleural space, we talk about transudative fluid, which is thin serous fluid like you might see in congestive heart failure where the fluid is backing up into the spaces.
I don't know if this is the right time to ask this, but what could you
Yeah, that's true, you're right, it isn't the right time to ask it, but that time is coming, so hang in. So there's transudative fluid, which is a passive collection of fluid, usually from congestive heart failure. And then there's an exudative effusion, which is usually an active process of infection, which usually causes an exudate, okay? When you stick a needle in the pleural space and pull out a transudate, it's almost like water. When you stick a needle in an exudate, you might not get anything out because it's thick. You might need to put a bigger tube in there to pull the stuff out, okay? So what are the findings in a pleural effusion? A pleural effusion means a pleural fluid collection. I can't necessarily tell just by looking at the chest X-ray if it's a transudate or an exudate. I just know there's something in the pleural space. The findings would be that the costophrenic angle gets blunted. Remember I showed you that really sharp costophrenic angle. When that gets blunted and shows this meniscus sign, think, if you will, about, you may remember from high school chemistry where you used a graduated cylinder and you had to measure 50 cc's of fluid. So you would pour it in there, and you would look at it really carefully to get to the 50 cc line, but you'd also see this very subtle meniscus, so this kind of curvilinear line, the interface between the glass and the fluid. That's called a meniscus. And you're going to see that curvilinear structure as the fluid layers in the pleural space. If you've got a lot of fluid in the pleural space and you lay posteriorly and the fluid goes ahead and runs and lays on the bottom and you're laying down, all that fluid is going to increase the density of that hemithorax in a uniform fashion. So that's called you'll see that fluid layering posteriorly. So here we see that sharp angle is gone on the left, and here you can see that meniscus, okay, where the pleural fluid is sitting in the pleural space. It's not in the lung. Remember, it's not in the lung. It's in the space around, the potential space around the lung, okay? And so here you can see that meniscus, here you can see the costophrenic angle is blunted. Now, here's a pleural effusion on the right side that's huge. Yes?
So, is it possible to get either the blunting or the meniscus with another disease pathology, or is it only with pleural effusion that will happen?
Generally, it's going to be with a pleural fluid collection. Okay? It could be blood. It doesn't. We're really agnostic here as to what the abnormality is. What we do know is if we see that costophrenic angle blunted in the meniscus sign, that there's some kind of fluid in the chest.
Okay.
Don't know what kind of fluid it is.
But
Okay?
that will only present if there's fluid in the chest.
Generally speaking, yes, that's right. But what can cause the fluid? A pneumonia in the lung adjacent to that portion of the will cause fluid and cause fluid in the pleural space. A tumor in the chest can cause fluid in the pleural space. Okay? All kinds of things can cause the fluid. But what happens when the fluid gets really, really large in the lung? First of all, what happens to the lung on that side? I told you that there's a huge right pleural effusion. The right lung gets completely squashed. Next time you take a sponge in your hand, think of it as a lung, a normal lung, and then squeeze all the water out of it, which is like squeezing all the air out of the lung. And that's what your lung is going to be like when it's surrounded by pleural fluid, okay, under pressure. Okay, because this fluid just keeps forming. Normally we make pleural fluid and we absorb it. So every day, all of us sitting in this room are in homeostasis with respect to our pleural fluid. We're making pleural fluid and we're resorbing it. But when something goes wrong and we can't resorb or we make too much, it builds up. And when it builds up, that sponge of lung gets squashed But what also is happening here? The heart is kind of here and it's maybe being pushed, but look at the trachea. Look what's going on here. This is being pushed from right to left. There's an interface here that's being pushed over. Okay? So this pleural fluid is so large in the right chest that it is starting to push over into the left chest. Now, there is a dividing line. It's not going. The fluid isn't going to run out and run into the left chest. Okay? There's no communication between the two pleural spaces. But when the pleural fluid gets so large, it will push everything away to the contralateral side. The abnormality is here. Everything's being pushed to the contralateral side. Unlike the atelectasis, the abnormality was on the right, but everything was being pulled to the ipsilateral side. We clear on that? So what happens when it's not fluid in the chest, but air in that pleural space? How could air possibly get in that pleural space? There's a whole host of ways that air can get in the pleural space. I'm in an MBA and I get a rib fracture. The fractured rib punctures my lung. What's going on in that lung? Air is being transferred in that lung. Air is coming in, air is going out. Well, if that lung tissue is compromised and communicates now with the pleural space, air is going to go from my lung into the pleural space. Every time I take a breath, I'm going to be pushing air into the pleural space. It probably isn't going to be able to get out very easily. Every time I take a breath, I get air in. I might be able to get into some kind of homeostasis where there's air in my pleural space and air in my lung. But air in the pleural space is never normal. Okay. So what happens is that this air gets between the visceral and the parietal pleura. As the air accumulates, the visceral and parietal pleura separate. Okay. So now you've got the visceral pleura sitting along the lung, and you've got the parietal pleura sitting along the chest wall, and there's a space, there's a gap. The gap is now filled with air. I should be able to see that on the chest X-ray, right? And what I wind up seeing is a thin white line of visceral pleura sitting along the lung, and then I see nothing but air on the other side. No vessels, no nothing, no normal anatomy. That's called a pneumothorax, and you're just not going to see it with this. And I'm sorry about it, but there are excellent examples in the book and online. Yes.
So does the lung, when you have a pneumothorax, does the lung get smaller, or does the parietal pleura just become more expanded?
Both. I described that wall valve mechanism before. What happens is, well, let me just do this and then I'll come back to it. Here's the aortic arch. Okay, this is the left lung. So you've got normal lung anatomy here, you've got normal markings, and now you've got this line. This is the pleural line inside. Okay? Outside of the line, there are no markings, it's just air. So what's happened here is that there's a sufficient amount of air in the pleural space that has caused the lung to start to shrink back. Okay? It's slowly decreasing the size of the aerated lung and increasing the amount of air in the pleural space. Here's another example. It doesn't read well at all, but there's a line here. There's a pleural line right here. Above the line, there's just black. There's no vessels. There's no markings. There's no nothing. And same thing here. There's the line, black.
So that line, that's the visceral pleura.
That is the visceral pleura sitting along the lung. The parietal pleura is still up along. It's stuck to the chest wall. Parietal pleura never moves. Okay. Now, there's something you always got to be aware of, because if you say somebody has a pneumothorax, you are essentially condemning them to a chest tube. Okay, so what you got to do is you got to evacuate the air that comes out of that is in the pleural space. Now, if it's really small, there is you can sometimes get away with just putting a small tube in and pulling the air out, maybe even pulling the tube out. But if there's air in the pleural space, that infers that there's a communication between the lung and the pleural space, and you've got to keep a tube in there until that communication heals over, and so that you don't have an air leak. It'll take it longer. So usually people get large bore tube into the pleural space, and we have to sit there for several days until the air leak is filled. Then you clamp the tube to the chest X-ray. Do the pneumothorax from that? No. Okay. Pull the tube out. Now we're going to take the chest X-ray. Do the pneumothorax from that? No. Good. But if you think about, if you're laying down on your back, you're really sick, and you're in the ICU, and he puts the cassette underneath you, takes a picture, fold, all kinds of stuff, and you can cause a line that might look like a pneumothorax. So you have to be able to tell the difference between the skin fold and the pneumothorax. And pneumothorax has a line on the edge, okay? And you'll be able to see more than one skin fold. It's usually in the elderly, and it's very difficult to see the pneumothorax in a patient who is supine, lung, because the air actually rises to the anterior part of the chest under the supine. You see pneumothoraces better when the patient is sitting upright, so that you can see so that air will go up to the top of the chest. Or if you lay the patient in the cubitus position, and then the air goes to the independent side. So patient positioning is quite important, but again, doesn't read very well. But there's an edge here that one might mistake for a pneumothorax. But then if you look out here, it's not very black. There are markings, there's little vessels. So that can't be a pneumothorax. There can't be vessels out here if that's really a pneumothorax. The last thing we're going to talk about, and then we're going to take a look at it, is the tension pneumothorax. This is a surgical emergency, and this is where you can really save somebody's life. There's that ball valve mechanism that I mentioned. So there's an air leak between the lung and the pleural space. So the patient takes in a breath. There's increased pressure in the airways. The air goes from the lung into the pleural space. And then the patient breathes out. And there's increased intrathoracic pressure, but for whatever reason, the air can't get from the pleural space back into the lung to get out. So every breath in puts more air in the pleural space, but every breath out doesn't decrease the amount of air. So you can imagine what happens over a short period of time. You get high pressure of air in the pleural space that starts to push all the mediastinal structures away. So here's a huge pneumothorax. This is the lung. That's it. All of this black is air in the pleural space. And notice how the trachea is pushed to the left, the heart is being pushed to the left, the right heart border is probably over here, right? And your patient is going to be extremely ill. They're going to be in extremis. Okay, they're going to be gasping for air. They're going to be in pain. So it's very simple. You walk up to them with an 18-gauge needle, you put it in the second and third interstace, and you just put it in, and you'll hear it. With all that air under pressure, it comes out. The lung re-expands. Okay? And then you breathe a sigh of relief. When you get air, and is there any question about pneumothorax?
Can you go back to the slide for that? 9 said that the opaque part is the lung.
Opaque, the opaque part.
Right, if I was looking at this, how would I know that that's air filled and that's the lung versus the lung being normal and that's like fluid filled?
Got it.
Just in that
If
area.
you could see this in real life, in a real situation, you would see that there are no blood vessels here at all. There's nothing. It's just black. On this side, you see vessels, you see little wispy things all the way out to the periphery, right? All the way out to the pleural space. Here is nothing. It's black. But you also see the mediastinal shift away from the abnormality. I suspect there's something going on here. The mediastinum is pushed away. There's this glob of white here. I don't see any lung markings. I have all those three things say that's attention pneumothorax. So sometimes you get air and fluid in the pleural space, and then it makes for some very interesting pictures because you will see a fluid level. You'll see an air fluid level in the pleural space. That air fluid level is really an important thing to see. And this is sometimes what you'll see after someone's had a partial or a complete pneumonectomy where their lung has been resected. Because you open somebody's chest, open it up to room air, take their lung out, close their chest back up, there's still going to be room air left in that chest, and there's going to be fluid and maybe a little bleeding. So what you get is, you sit that patient up, what you get is, you get This is all fluid. This is the water or the blood or whatever. This is all air. There's no lung here. The lung has been resected. Okay? So this is a hydropneumothorax. Hydro, water, pneumo, air, thorax.
So do you have enough capacity to change this position when the patient changes position, being always receiving oral capacity and not in some lungs?
Not necessarily. Consider a cavity inside the lung that contains air and fluid. I haven't shown any of those. Okay, so a cavitary lesion of the lung. Some tumors will get big. Their central portions will necrose. Okay, you'll get fluid. At some point, that might actually communicate with the airway. So now you've got air and fluid in a cavity in a lung section. If you turn the patient, you might get an air fluid level going this way, and then you turn the patient, and then it goes the other way. But it'll stay in the same position. Okay.
So this, sorry, go ahead. That picture, the pneumothorax, hydropneumothorax is that's all
In this particular case, the lung has been removed entirely, so this is all in the pleural space. Right? Yeah.
not just in the total cavity.
Well, in this particular case, it actually is just in the thoracic cavity, because there is no lung there. However, you can get a hydropneumothorax when there is lung there, okay? When that would only be in the pleural space.
And it would look like that too? Or
It would look like this, maybe not nearly as dramatic as this.
Okay.
But you would have an air and fluid level somewhere in the pleural space. It might only be here. There would be air above and fluid below, but the rest would be normal lung.
Would it push mediastinal structure?
Only if it was huge.
Okay.
Okay. In this particular case, there probably isn't. It's probably a total luminectomy. Okay, so they took the entire lung off. If there were any lung left in this post-op, there would be a chest. They wouldn't allow it to look. Okay, they would want the lung to expand, right? So there would be a chest tube, and they would have done that in the OR, so you'd never see it. So for the opacified hemithorax, there's the complete lung collapse where the mediastinum shifts toward the area, toward the abnormality. That's the ipsilateral shift, right, for lung collapse. There's a large pleural effusion where the mediastinum shifts away. Okay, that's the contralateral shift for a big space occupying something in the hemithorax. And then there's complete lung consolidation where the entire lung may have a pneumonia. But generally speaking, it's not going to shift the mediastinum one way or the other. So large pleural effusion, mediastinal shifts away. Complete atelectasis, mediastinum shifts forward. Complete consolidation, no mediastinum shift. What's that?
Collapsed lung.
Who goes for consolidation? Who goes for large pleural effusion? Mediastinum shift away. Goes for complete atelectasis, mediastinum shift forward. Correct.
I don't know.